close.
Yes, it's right on the east side. So, good afternoon, everybody. I'm gonna try to share my screen with you. And I don't know what I'm doing now, of course. So, share content. That's it. Can you see my screen now?
I can, and it looks great. You're all set.
Excellent. So, good afternoon. As Heather stated, my name is Jose Ramon Fernandez-Pena, and I'm very grateful for the invitation to speak with you today about health equity. I have worked in the health sector in a number of areas and angles in Mexico and in the United States for the past almost 40 years. And it's this right through the private practice as a primary care physician in Mexico, through Bellevue Hospital in the area of quality management for surgical services, to community-based clinics in San Francisco, to academia, and now to administrative positions and a leadership role within the American Public Health Association has taught me a lot and continues to teach me not only the importance of the language we use, but the intent and the meaning of the words we use. So we're going to be talking today a little bit about health equity and what it really means and how do we get there. I'm reminded also of the fact that thinking of my life at Bellevue Hospital, the 4 years that I worked there, I started working in the Office of Quality Assurance, that they became the Office of Quality Assessment and Improvement, which then became the Office of Quality Management, which after another year it became the Total Quality Management. So the language we use in the health sector, you all know, evolves with time. And sometimes we mean the same thing, and sometimes we learn that what we were saying before is perhaps not exactly what we were meaning to say. And we're going to be talking about a little bit of that today. I also want to thank you for sending me some questions ahead of time, as those really helped me try to tailor this presentation as much as I could to your interests. I've saved some time at the end for Q&A, but please feel free. And I don't know, Heather, how you're going to do this, but I am happy to take questions at any time. So before we start, I just wanted to give you a quick oversight of the American Public Health Association. As you probably know, it's one of the oldest public health associations in the world, certainly in the United States, with it's going to be 150 years next year, founded originally in New York City. And here you have the glances of our mission, our vision, our tagline, and what kind of work we do in the association. We have about 40,000 plus members in the US and in many other countries as well. The largest component of the association is its student assembly, which has about 7,000 members that are very actively engaged in all aspects of public health, from medical care to social work to, you name it, nursing and veterinarian health and many other components. Like many organizations, in not all organizations, we have a strategic plan, and we were working on this particular iteration of the plan over the past few years. And in that process, we identified 3 key components of our work that are needed to achieve our vision of becoming the healthiest nation in a generation. And this work started from the knowledge that the US is ranked 37th globally in life expectancy, and that there are a number of ways to try to bring us to becoming the healthiest nation. And those 3 pillars you can see here in this Venn diagram go from strengthening the public health practice to building a public health movement and aligning organizational capacity and infrastructure. And we've been working on all this. Strategic plans are living documents, so we are getting ready to the next iteration of the plan. In this process and in this quest, we affirmed and reaffirmed that one of our core values of the association since the beginning of its existence in 1872, it's going to be the 150th, that health equity is in fact one of the core values and one of the most important drivers of the work that we do within the association. The conversation about health equity has taken different shapes at different times. The language has been evolving. We have been talking about equality and equity and a number of different terms we've used over the years, and we're settling on what we mean by talking about health equity today. And I mean, any Google search will give you 7,500 different definitions. I like this one in particular that was put out by the Robert Wood Johnson Foundation a couple of years ago, where it really nails it in the sense that it is a lot of health equity is not contingent on the individual. It's not about the individual choices or the individual behavior, but it's really providing us a better understanding of the context in which life and health and disease happens. And with that understanding, our work is geared towards attempting to remove those barriers or to remove those obstacles that prevent people from living their full health potential. You probably heard or read in the news that over the last, I think it was last week, this tremendously large tanker was caught up in the Suez Canal and blocked it for a number of days. So somebody took this picture and then put this caption on it. I found it on the Facebook page of one of my friends, and I thought it was just a wonderful representation of this former belief that we used to pay a lot of attention in trying to make a difference by changing behavior or by suggesting that personal health and personal growth was completely contingent upon personal choices versus understanding the structural problems that create this kind of disparities and inequities. If you take a look at this chart I found at the Kaiser Family Foundation, there's a very clear description of what are the social determinants of health that we're talking about. And also, I think it's important to note that on this chart, you don't find race nor ethnicity. And the reason neither race nor ethnicity are listed here is because as themselves, they are not social determinants of health. Racist practices are social determinants of health. Redlining policies that determine where people could live or not are social determinants of health. Health insurance that is contingent upon employment is a social determinant of health. Food deserts in specific areas which determine the food choices in many communities are social determinants of health. So changing the focus from the individual behavior and understanding the larger context in which these behaviors happen is what is going to provide us the key or the tools that we need to be aware of and understand their impact on the health in order if we're going to get towards a level of equity. This is probably one of the things we all learned at some point, that defining a positive by a negative is not a good idea, but I'm going to take liberty here, and in order to better illustrate what health equity is, let's talk about health inequities for a moment. So if we think about how these uneven distribution of the burden of disease happens and who it happens to more often and what are the reasons behind that happening. So when we think about, for example, why are African-American infants 3.2 times more likely to die from complications related to birth weight, to low birth weight, as opposed to white infants? Or when we think that why is there a 25-year difference in the life expectancy for babies who live just a few miles apart from each other in New Orleans or in New York City or in so many other areas? So it's important to distinguish health disparities from health inequity. Disparities are defined as a difference in health outcomes between groups within a population. And while the terms may seem interchangeable, health disparity is different from health inequity. Health disparity denotes differences, whether unjust or not. Health inequity, on the other hand, denotes differences in health outcomes that are systematic, avoidable, and unjust. And I read an article by Lederman where I got this information from. But thinking about it through this lens, I think helps us contextualize again what we are saying when we're talking about health equity or health inequities. How are we doing thus far? Comments, questions?
Looking good. I don't have any questions in the chat box at this point. So if you do have questions, folks, please feel free to go ahead and put them in the chat box, and I will stop Dr. Fernandez-Pena and ask those for you.
Thank you. Okay. So how do we achieve health equity? How do we get there from where we are? A lot of this work happens at the macro level and in the policy space. And I'll talk about that in a minute, but on a more micro, local level, there are many things that we as individuals or as institutions may be able to do in the short term at least. And these range from establishing unconscious bias trainings for all staff, to providing babysitting services for patients for whom a barrier to access the services is the cost of finding a babysitter. Or is our location next to public transit? Or can we provide reduced parking fees for people who drive to seek services in our institution? Hiring practices with an eye to reflecting the diversity of the communities being served. One example that I like to bring up, because somebody asked about it and because I think is really, really important, is in the current situation regarding the COVID vaccine hesitance. I think that it's important to stop for a moment, and before we go down the road of hesitance means we need to encourage people or educating people about the importance of the vaccine. Perhaps a more effective approach at this point is to go literally like behind the curtain to understand what is behind that hesitancy or behind that fear. And we may find that instead of hesitance, what we may be reading as hesitancy is a problem of access. So it's not necessarily that the African American community has had a most unfortunate experience dealing with the health services for many years since Tuskegee and beyond that, or Latinos who have been sterilized against their will for a number of years here and in Puerto Rico. But the answer may be transport. So it's not that they don't want to get the vaccine, it's that if the vaccine came to them, it would be easier for them to access it. So this is what it's important in terms of turning the table around and trying to understand what is happening that is preventing people from either enacting safer behaviors or moving ahead with their intent to do something they know is better, but they don't have the tools, the means, or the space, or the surroundings to achieve them. APHA works on a lot of these spaces, and I'm going to be talking a little bit about APHA priorities. For example, we do a number of trainings and things and the annual meeting, and we publish a journal, of course, but we're also involved in the advocacy space. And for this year, what I'm showing you here is what are the advocacy priorities for APHA. And you see advancing racial equity. It's one always that we have on our list. I'm sorry if you're hearing an ambulance, it's right what's happening in my neighborhood. So APHA has a stake on all these areas, and some of the things that, some of the initiatives that we push and are these three here that I brought up to you. One is National Public Health Week, which is next week, actually starts next week, and this year's theme is Building Bridges for Better Health. You can find all the information about National Public Health Week following this link here, nphw.org. There's a number of resources and materials for the themes of every one of the days of the week and what you can do at your individual level, at your community level, etc. The Speak for Health campaign is another a series of tools that APHA has created so that members can advocate in their local communities. So for example, the link that I put here, it will take you to a page that has a fact sheet for the state of California. So when your Congress people or your senators go back home for the recess, you can attend a town hall or something like that and speak specifically about the particular needs of your state or your community, where you can speak as to why is it important to continue to fund the CDC and how CDC dollars are spent in your community and how that impacts the work that you do or the health of the community you live in. The Get Ready campaign is another program we established a number of years ago, and it's a pretty innovative campaign that uses social media tools to creatively convey the importance of preparedness for the general public. And if we have learned something, this year, is that the lack of preparedness is really a very, very important and structural problem that has very much contributed to where we are with the pandemic today. I see something here now. All right, so this is the Speak for Health campaign that I was talking about a minute ago. Another area, another piece that we're involved with is this happening actually next week is the Policy Action Institute. And this Policy Action Institute brings the importance of policy to the forefront during National Public Health Week, which, as I said a minute ago, is next week. There are a number of elected officials, policy experts, and influential speakers that are going to be talking about a number of things, of course, from COVID-19, climate change, and how we effectively can communicate across party lines in order to ensure adequate funding and support for policies that will help us all remain healthy and enhance equity and reduce disparities. There's a link as well here where you can find the events that are going to happen in there. Another thing that we started doing a while ago was a series of webinars on the topic of advancing racial equity. And I don't know if any one of you had a chance to watch any of these, but it's really an amazing series of 6 webinars on how to work towards achieving racial equity. So rather than me trying to tell you here in the span of an hour the things that we can do as a society, as an individual, or as an institution, I invite you to look at these webinars. And I believe Heather, you can, I'm pretty sure they're certified for CME credit. It's a specific, especially relevant matter to address as we have witnessed so much violence over the past year and just the past recent weeks, the despicable attacks against Asian Americans. So understanding what is behind this racial equity is critical to understanding what lies behind achieving health equity. These are 2 inseparable components that is often uncomfortable to get into for those of us that may not come from communities that have been historically marginalized. But it's an important conversation to have and to, I think, as we build our own awareness of these matters and we can find ways to begin to redress those disparities, certainly acquire the language and the skills to work with others in this space. Another really important piece that we have been doing, and this came up also through the lens of equity, these COVID conversations that we have been having with the National Academy of Medicine. We've had, I think it's about 18 up to now in this series, and they started talking about the science of social distancing and the last one was on COVID-19 variants and vaccines. So these conversations have spanned the whole life of the pandemic, because we literally started about a year ago. And it'll be interesting to look at them in hindsight a couple of years ago to see how we were thinking about the issues that we're facing today. And to really, like pandemics do and natural disasters do, I certainly remember my first pandemic, the HIV pandemic, where this series of structural inequities were in fact accelerators of the spread of the disease and accelerators of the destruction that ensued when there were no infrastructures in place and where if here now we have seen the impact of racist and marginalizing historical practices on African Americans and Latinos and Native Americans back in the 80s, homophobia was a trigger that was behind the widespread of the HIV pandemic before we began to take notice of that and began acting up and acting otherwise against it. So I invite you to look at these webinars. They're really, really comprehensive. And again, they provide us with tools and skills to begin to understand how we can be players and actively engaged in efforts to achieve health equity. And I can't believe I just took myself out of slides, but I did. So this is, I think, a good place to stop and see what kind of questions or what kind of conversation we may want to engage in right now.
So I do have one question in the chat box here from Jill LaDuca. It says certain cultural belief systems do not trust modern medical care. Is this considered a health disparity, health inequity, neither, or both?
Can you say that a little slower, please?
Yeah, sorry. I was talking New York speed there. I apologize.
I know.
Certain cultural belief systems do not trust modern medical care. Is this considered a health disparity, health inequity, neither, or both?
Well, certain cultural belief systems do not believe. So, for example, individuals who have been raised with traditional Chinese medicine may not consider that Western or allopathic medicine is useful. Is this considered a matter of health equity? I don't think so. I think that we, as providers of allopathic health services, need to be knowledgeable and mindful about that. And I think that if we have an opportunity to collaborate with providers that may be better suited to providing services than we are, we need to be open to that. When I was living in San Francisco, I taught for a while at the American College of Traditional Chinese Medicine. I taught a class on cross-cultural communication, and what I was teaching the students of traditional Chinese medicine was how to converse with allopathic providers in order to ensure that there was an understanding. So when you tell somebody that you felt the liver pulse, a person that is not trained on that space will not know what you're talking about. So I don't think it's a matter of equity. It's a matter of equity. We think that the only way these individuals are going to be able to receive health services is if they can find a local Chinatown and go see a local Chinese doctor or any other form of Ayurvedic medicine or any other kind of medicine.
Joe, if that didn't answer your question, please feel free to go ahead and post a follow-up in the chat box. Any other questions out there? I don't see any hands. There's one hand. Let me see.
That's me.
Okay.
Heather, this is Dr. Kamiar, Roque Kamiar. So thank you very much for coming and giving this lecture to us, Dr. Pena. I appreciate you coming. I just had a couple of questions. One, is there any effort to put this topic, this issue, into the medical education of medical students? We hear about health equity and all these disparities and issues like that, or the consequences of that, or what they result into, but we don't go to the causes of it. And I really think that if we teach this, at least in the pre-medical education or the early stages of the medical education, this would be more beneficial, don't you think so?
Absolutely. Absolutely. I completely agree with you. And I think that the AMC, the Association of American Medical Colleges, is aware of this, and they are beginning to. So some medical schools on their own have made this one of their priorities. I know, for example, right in your neck of the woods, and Kaiser Permanente Medical School is very, very deeply committed to social justice and equity and have included aspects of all this in their curriculum. The Association of American Medical Colleges, in its web pages and materials they have ready for students to prepare for their application to medical schools, suggests more and more the importance of taking courses that are beyond the biomedical prereqs of, the chemistry, biochemistry, etc., and also take courses on social sciences, on public health, on matters of social interest to a future provider. Absolutely, we must not wait until people are working in the health sector to start talking about this thing.
Yeah, the second question I had was that how the United States compare with other countries, particularly advanced countries in this issue, in this particular field. Are we much behind? Is France or Germany better than ours? What do you think of that?
So I don't have a concise and clear answer to that question. My take is that even with all its faults, the United States is probably ahead in some of these areas because of the statements or the notion that this is a country essentially of immigrants built by willing and unwilling immigrants. And so the notion of a more multicultural society is perhaps a little better embraced than in countries that have been historically more monocultural, even though their economies now, like everywhere else, may depend more on immigrant workers in Germany, in France, in the UK, or in any other places in Europe, for example. So short answer, I don't know. Guess answer, probably.
Thank you. Thank you very much.
Thank you for your questions.
All right, I have another question for you here. Thank you for the question, Sunday. Any recommendations on how to create the sense of urgency or high need to providers or systems to seeing the importance of addressing the social determinants of health?
As in most cases, data speaks. So I think that thorough data collection that can demonstrate the need for X, Y, or Z is the first place to start. But data is kind of anonymous in a way. So I think that working with the community affected and working with them to be the speakers of their own truth and of their own needs is also a critically important piece. So partnering, when we are providers at a building that is doing primary care or is doing surgery or something, it's perhaps not obvious or easy to get out of that role and then do community organizing work. But identifying assets in the community that do this work and partnering with them with concrete data that they can use to advocate or to demand, if that's what's needed, or to present a plan to a funder or to a regulator or a legislator is a very effective way of moving ahead with this, especially when it's not me talking about your needs, but it's me talking about my needs.
All right, great. Thank you. Keep the questions coming, guys. Just trying to give folks a few seconds to see if they have anything else. Go ahead, Dr. Kamiar.
Yeah, I just wanted to see if there's any, are there differences in between the states of the United States? The different states have different policies towards this, or some state is better in this area than the others? If you could mention about that.
That's a great question. I think that because the population is so different across the country, the work and the plans to address health equity or racial equity are very, very diverse. For example, we cannot talk about North Dakota and California in the same sentence. So the diversity of California or the diversity of New York or the diversity of Texas or I don't know, of Washington State are not comparable to what's happening in, I don't know, again, North Dakota or South Dakota or Montana, for example. I mean, I lived many years in California, and I think that the innovation in the state of California is in general ahead of the rest of the country in terms of models of service, in terms of ideas and suggestions on how to approach different health disparities. For example, I was involved with Kaiser when they were developing a training program for health care interpreters with City College of San Francisco. So that was not happening anywhere else in the country, a program to build bridges or to eliminate barriers for services by using trained interpreters, not informal interpreters. So I think there are strong differences, and if you look at the data in terms of disparities and in terms of disproportionate burden of disease, you always find that it's Mississippi, Alabama, Arkansas, that part of the country, of the Deep South, that comes out with the biggest disparities and the worst health outcomes across the board. So it's also poorer states on many ways, and there are also historical issues that still prevail this day in how systems that were run or created. And the unspoken animal in the room, I think, or elephant in the room in most cases, is the politics that are always at play in these matters. And I think that for us in the health field, it's sometimes like the proverbial third rail that we don't want to touch. But if we're not going to touch it, it's important that we be aware that it's there and work with partners who are willing and able to go there.
Appreciate it.
I have a question for you, actually. I'm curious if you can provide any examples of some best practices of different ways that maybe some medical groups or some communities or even folks in the hospital setting that maybe aren't seeing people on an outpatient basis have done to address some of the social determinants, whether it's transportation or access, et cetera.
So I can't give you any examples of any practices that hospital systems may have organized. I can tell you that in some places that organize their care around multi-tier teams, not multi-tier, that cross-disciplinary teams find themselves being more effective in delivering the services. In terms of a provider team that includes a provider, a social worker, a health educator, a nutritionist, and somebody else is better able to see the complete picture of the patient and then address their needs accordingly. So if I'm the surgeon and I need to remove a tumor on this person's kidney, working in that entire context, it's easier to see, will the person need transportation to and from? Will the person need food delivery services? Does the person have whatever additional supports they will need to ensure their recovery post-surgery? So when they come to the clinic the next time, we can see that they're able to adhere to the medication regime, they're able to adhere to the diet restrictions, et cetera, et cetera. So that's where comprehensive multidisciplinary teams are very, very effective in reducing inequities and therefore pushing for better health outcomes. Is that what you're talking about, Heather?
Yes, thank you.
So I mean, I think in California, you still have the comprehensive perinatal services program that requires that your team have a provider, a nutritionist, a health educator, and a social worker precisely for those reasons.
Dr. Kamiar, did you have another question, or is your hand just still up from last time?
Oh, I'm sorry.
No, you're okay. I just wanted to make sure not to miss you.
No, I'm all right. Basically, I think what we want to know is how California is doing as far as all these recent pandemics and everything else being considered, how are we doing compared to, say, New York State, or other parts of the country?
Well, you probably know better than me. It's been a while since, it's been 4 years since I left California, but California is its own country in many ways. And Northern California and Southern California are pretty different in many ways. And then there is that 20,000 square mile area called the Central Valley that is another reality unto itself. So there are many Californias, I think. And what we have seen in terms of how the epidemic has spread or not is reflected on the geography and the politics and the economics of the state. So, I mean, I really don't want to get deeper into that, but
Sure.
there's, I mean, you know what I'm talking about. I'm sure you know
Right.
what I'm talking about. So it's different than, for example, the state of Utah, that has been very pragmatic in its approach, and I don't think that there's as many differences in northern Utah than in southern Utah. It's a much more coherent, that's not the word, more similar approach that can go from top to bottom without that much diversity or disparity in ways of thinking or disagreements in terms of what constitutes healthier behaviors. And I mean, and all the things that we've been seeing in terms of mask mandates and opening restaurants and opening venues and access to vaccines, it's different. I think California is its own phenomenon, for good and for bad.
I agree with you 100%. I
Yeah.
think it is, unfortunately, it's a big burden as far as tax and whatnot is concerned. But from what I see is that if you raise the taxes to better service this part of the living in California, then people go somewhere else, and they just, the corporates will leave, and individuals will leave. But if you don't tax, you cannot afford these things that California is presently doing. So it is a big burden on the Californians in general. However, from comparing to other states and even other countries, I think California is doing a great job. The way we deliver care here is just incredible. We have a patient, we have, for example, given the translation services, we gave the transportation services, we gave, some of medications that I pay a copay myself, say, to a significant expense, we provide them free. And those are the kind of things that California is far ahead, and that's why we get a lot of immigrants coming to this state. So my feeling is that California is doing better. I don't know if this a true statement or not.
I do think there's an element of truth in what you're saying, but it's also true that not every person in California or in the country experiences their contact with the health sector the same way. And there's histories and there's facts that have followed individuals and communities for years that continue to experience unequal treatment and unequal access to services. And as somebody had asked before, in terms of the cultural beliefs and barriers, there's a history of oppression, and there's a history of oppression that results in diminished access to services for specific communities. And depending on where we are in the cycles of politics and others, we find, for example, very racist and anti-immigrant rhetoric going on and on and on for a number of years that effectively deters people from accessing services. And so this is not because X, Y, or Z or black or Latinos or are unwilling to seek health services, but when you are confronted with a history of rejection, a history of lies, and a history of mishaps, you're going to be less willing to put yourself out there or to even seek those services. And if you are an immigrant and you may not be fully authorized to work, or even if you are, if you hear that the fact that you're accessing health services may make you a burden and may be actually your ticket out of this country and back into your country, I'm not going to access those health services either. And if I'm in the middle of a pandemic and I am not going to access I'm not going to go to my gynecologist for my breast exam because of the complication of matters that are happening in there, you get to build those disparities and you continue to build that inequity in different communities over time. So we cannot just pretend that we don't have 200 plus years of questionable practices. So we have to own up to those historical facts that put us where we are today. And we have to own it. We have to own that we have screwed up multiple times in multiple places. So and it's not just a futile exercise in atonement. It's really an intentional effort to reduce that, to face that history, accept that history, acknowledge that history, and attempt to build that trust and those partnerships again, while removing those remnants that are still in place and still keep people out of the system.
Joe, you had a question?
Yes. Thanks, Doctor. I really appreciate you. I was just wondering, how do you see this moving forward? I mean, we're in the middle of a pandemic. We have 30 to 40% of the population doesn't believe in science or refuses to protect not only themselves, but to protect themselves from others. We look at some of these other countries now, France in particular, their numbers are going up again. And we know the trend has been what's happened in these European countries usually ends up in America at some point. And we've got states that have lifted the mandate, not only for this pandemic, not only the disparities that are going on in the Black and brown communities, but the fact that we have so much disinformation out there now. How are we ever going to get through a pandemic?
I wish I had the perfect answer for that, and I don't. And I think that speaking with that clarity and with that clear understanding of what the situation is may help us begin to figure out our way out of this. I think in my mind, I need to cut this down into different pieces so I am able to process and work towards different goals. So if I'm meeting, for example, or if I'm confronted by a group of individuals or communities that have made up their mind that are either typical anti-vaxxers or not and have decided that they're not going to do something, I'm probably not going to spend a lot of time trying to convince anybody of anything. I'm going to try to work with the so-called hesitant space and understand what's the question behind the hesitancy and try to get there. I think that for those of us in the health field and the public health field, we have not always done a good job in getting the information out and conveying what we know in terms that are easy to understand and that are easy to digest. We have floundered. We have given mixed messages throughout the pandemic. We said the masks were not good, the masks were good, the vaccine will do, the vaccine will not do, this will cure, this will not cure. And we have not spoken with a consistent voice. We have not spoken with a clear message that, and when we have tried to speak that message in other languages, we have not been successful in using the proper languages, or we have not been mindful of the cultural beliefs or values that different communities would react to. We have just not been effective, and part of the reason we have not been effective is that our midst really doesn't look like the field it intends to serve. So when 30% of the country or 40% of the country does not believe in science, I am at a loss at that. I am at a loss with my own relatives who argue with me that, still talk about there's a microchip in the vaccine. I am at a loss when I hear that they're not gonna get vaccinated because something or other, or those who believe that this was just a hoax initiated by some company that wanted to make money out of this. I think that if we learn anything moving forward, so when we're hit with the next pandemic, as we will be, unfortunately, we better learn and capture the lessons learned in this one of what we did wrong and try to do it right. And one of them, I think a key piece is the ability to speak with one coherent and clear voice. I didn't want to go there, but I think that when the leadership is invalidating the science and is invalidating the messengers, that's a very, very, very dangerous position to be in. And I would then go from there. I'm just getting into deeper waters than I wanted to, but this speaks to me also about the importance of education in general, the importance of access to education, and the importance of civic education, and the importance of protecting voting rights, and the importance of ensuring access to information that is, if not devoid, but that is clear, honest, digestible. And when I was working at San Francisco State, there was a program on the human sexuality program. And the human sexuality program developed a component with funding from the Ford Foundation, I think it was, whose job was to immediately respond to any press releases or anything that were homophobic or transphobic or anything like that, to immediately respond with factual data on the misgiving or the misinterpretation of findings or beliefs. So if we were able to get to that point where we had a respected voice or a set of respected voices that were not pandering to fear, and this perhaps I'm naive even thinking about this, but I think that's a big, big, big component of being better able to address the next pandemic.
Thank you. I appreciate you taking the time to answer my question. It's just I think if the message would have came out, we know that the last pandemic, for instance, lasted 2 years. I think we would just prepared people for that from the beginning, we'd be in a lot different situation than we are right now, so.
I hear you loud and clear.
Thank you for the question, Joe. Joe LaDuca, you had your hand up.
Yes. Hi, Dr. Fernandez-Pena. I really appreciate you being here today. And I was wondering, as we have to update our community health needs assessment every couple of years, is the APHA helping to introduce specific framework for health disparities and health inequities to make that a critical component of these needs assessments? Thank you.
Mm-hmm. I don't know that we are actively doing that, but I invite you to look through the website of APHA for what may be resources that you could be using in that plan. And also, I wonder if the association, I'm not exactly sure. I think not, but I will be happy to get back to you with with an answer to that. If you, Heather can get you my email, or I can give you my email here.
Okay, thank you very much.
I'll connect with you, Joe.
Thank you.
Any other questions at this point? We have about 10 minutes left if we want to use it. Otherwise, we can give people a few minutes back today. I will say that some people have had to hop off the meeting to join another meeting, and they've all been saying thank you, and they really appreciate the presentation. I do see a question here in the chat box. It says, do you have any public health perspectives regarding how to motivate individuals to engage in healthy behaviors? The efforts to reduce disparities are critically important, but unhealthy behaviors persist among individuals who are relatively well educated and have access to resources.
Yeah. So I was a professor of public health for a number of years, and one of the classes I taught was program planning and evaluation. And in that class, students were expected to write a proposal to address a health disparity. And in that work, they had to define or describe the disparity they wanting to address with the program they were proposing, and a theoretical framework on which their intervention would be founded. And oftentimes the first level of theoretical framework for this kind of interventions is the health belief model. If you work with an individual and they understand that changing their behavior is going to be better for them, they will change their behavior. Or the other model, the Prochaska model, the stages of change, or trans-theoretical model, where you understand that people are in different stages of changing their behavior, and they're either pre-contemplating, contemplating, in action, or they relapse, and you design an intervention for a particular stage of the behavior you're talking about. And then many students ended up talking about the political economy theory model, in which we go back to the structural elements that may enable or foster those desired behaviors. But Bandura's theory of self-regulation also talks about when an individual is able to watch themselves in an unhealthy situation, they are more likely to understand what were the triggers for their unhealthy behaviors and then modify their behavior. So all these combinations of efforts work in some cases for some reasons and for some people, but there's no one answer to the case, I'm afraid. And I mean, whoever heard anywhere that smoking was not good for you? Everybody, right? And yet we see people smoking. It's not that they're dumb. It's not that they don't have access to information. It's that for some reasons they are unable to make that change in their behavior. So I think that depending on what we're talking about, to whom we're talking about, and the strategy we take to first understand what are the barriers between the barriers to the inaction of the safer intentions. That's where we're going to find the sweet spot of developing an intervention that perhaps would be successful. But human nature is human nature, and I think the idea of we live in a continuum where sometimes we're able to do some things and we're able to maintain some things. Think about going to the gym or your diet, and how long can you sustain those things. It will vary from person to person over time.
Great. I have one more question here for you. There's two parts to it. You may be able to answer it all at once, or maybe it is two different things. It says, how do ACE scores factor into public health? And then, is there evidence that trauma-informed care mitigates social determinants of health?
Well, trauma-informed care, like trauma-informed education, I think is a really important and highly effective way of addressing issues at hand. It's again understanding the context in which things happen, and it's building services or interactions that are cognizant of how individuals will react to different approaches. So I think as for trauma-informed care, especially in particular for individuals who are the survivors of domestic violence, or they are survivors of genocides or natural disasters or things like that. It's a very, very important and very valuable tool to address those situations. In regards to the other one, what was the other part, Heather?
How do ACE scores factor into public health? So adverse childhood events.
Adverse childhood events, again, I mean, there's so many. It's understanding the context of the individual. It's understanding where or how it often happens that an abused child becomes an abuser with time. So adverse childhood events is another trauma event: the loss of a parent, the witnessing of domestic violence, the experience of homelessness, the experience with living with a parent or both who have been incarcerated because of substance use. And all these adverse childhood events impact the mind and impact the way people make choices. And this kind of trauma tends to replicate itself if unaddressed or if unattended. So through a health equity lens, the awareness of that situation and the intent of addressing those situations concretely with the correct tools for that particular person are essential in order to get positive health outcomes or educational outcomes or social interaction outcomes, healthy relationships. So it impacts all the aspects of our life, and it impacts how we relate with the rest of the world.
Great, thank you. And with that, we are almost at 1:30. So I don't see any other questions in the chat box. There are a number of comments, and I did want to read this one. It says, "Thank you so much. Thanks for addressing the tough questions. We are all challenged as we interact with friends and family who are misinformed. We need to know how to approach these interactions to create a positive outcome." So
Amen.
I think everyone is and myself included, is very appreciative of your time today and your expertise. So we thank you for making the time for us today. And if anyone has any other questions, please let me know. I will forward them to Dr. Fernandez-Pena. And everyone have a great afternoon and a good weekend.
Well, just thank you very much, Dr. Fernandez. Thank you very much for accepting our invitation.
Thank you for inviting me.
Just we'll be in touch. I'm sure there's a lot of things that we have to discuss in the future as well.
I hope so.
Thanks.
Take care, everybody.
Perfect. Thank you. Thank you so much. Have a great evening.
Thank you, Heather, for arranging this.
Thank you.
Bye.
All right. Bye-bye, everyone.